This talk will cover the book chapter on neurocritical care in children. In this discussion, we will provide a brief overview and then discuss leading diagnoses in pediatric neurocritical care, the neurologic assessment in the pediatric population, ways to prevent secondary injury in children, discuss pediatric stroke, sodium and water homeostasis, as well as the diagnosis of brain death in children. Regardless of a primary diagnosis, the neurological outcome has the largest impact on quality of life. Pediatric neurocritical care involves a very close collaboration between services including neurosurgery, critical care, neurology, and many others. There continues to be a focus on functional monitoring, evidence-based guidelines and interventions, which have been designed to prevent and reverse evolving pathology as well as secondary pathology of nervous tissue. The end goal is to lessen the impact of acute neurologic disorders in critically ill children by optimizing the timely delivery of care. This slide details the leading diagnoses in pediatric neurocritical care, including traumatic brain injury, central nervous system infection, status epilepticus, stroke, and the others here listed below. Many tools are available for monitoring neurologic function in critically ill children. EEG recording is well established as an essential modality for the detection of non-convulsive seizures in adult and pediatric ICUs, and now has become increasingly standard of care in this setting. Measurement of intracranial pressure, brain tissue oxygenation, the use of transcranial Doppler, these are all expanding within the pediatric ICU. Numerical thresholds for risk of secondary brain injury have been proposed for ICP, although normal values do remain controversial, as do the way that they vary with patient age. Consensus does not yet exist for a graduated ICP treatment threshold based on age, apart from the customary threshold of less than 20 millimeters of mercury. The most recent Brain Trauma Foundation update supplied consensus-based guidelines for management of severe pediatric TBI. 22 recommendations in all, covering topics including neuroimaging, medical therapy, temperature control, nutrition, surgical intervention, and more. Studies have shown that protocol-directed care based on such recommendations have improved survival and outcomes. Clinical management in the ICU should include assessment via complete neurologic exam, including attention to mental status, changes in reflexes, cranial neuropathies, asymmetries of tone or strength. Obtaining the GCS score is essential, the Glasgow Coma score, and produces reproducible results between observers, yet does not replace the value of a full neurologic exam. In the examination of critically ill children, attention to subtle changes in exam findings is paramount, and collaboration between teams helps to detect and prevent progression of acute neurologic insults. Impaired cerebral autoregulation in severe TBI and other critical illnesses can expose the brain to effects of secondary sources of harm, such as hypotension, hypoxia, hypercapnia, or hypocapnia. Secondary insults can aggravate a primary neurologic process, and in severe circumstances can result in life-threatening events such as global hypoxic ischemic brain injury and the like. The choice of diagnostic studies includes imaging, EEG, ICP monitoring, and any therapeutic interventions to minimize secondary injury can depend on the etiology of the primary insult. Inadequate perfusion can have a detrimental effect on the brain. Cerebral perfusion is typically described as the difference between mean arterial pressure and mean ICP. Current guidelines recommend that a minimum CPP of 40 millimeters of mercury be maintained in children with TBI. For children older than 2 years, the threshold should be 45 or 50 millimeters of mercury, with higher thresholds as age increases. On the basis of data from adult patients, a CPP of 50 to 70 millimeters of mercury is typically recommended for older adolescents. Children with CPP below these thresholds tend to have worse outcomes. Published data has shown that secondary injury in children occurs at lower ICP thresholds compared to adults, and that impaired cerebrovascular autoregulation can reduce the ability of the young brain to tolerate ICP insults. The main indication for ICP monitoring in critically ill children is TBI. Children of every age are at risk for developing intracranial hypertension with severe potential sequelae. Mainstays of modern therapy for elevated ICP include hyperosmolar therapy with 3% saline or 23.4% saline, avoidance of hypotension and thus hypoperfusion, avoidance of prophylactic or prolonged hyperventilation, use of CSF drainage, high-dose barbiturate therapy, or surgical decompression when indicated, as well as initiation of early enteral nutrition within 72 hours of the injury, and consideration of anti-epileptic medication to prevent early post-traumatic seizure. Interventions such as immune-enhanced diet are not recommended. Corticosteroids, furthermore, have not been found to reduce ICP and trauma, nor do they improve outcome. Even without increased ICP, low blood pressure does predict poor outcome in patients with brain injuries. Normal MAP values for age and a normal ICP of 10 millimeters of mercury can help to estimate threshold levels. Normal MAPs include 50 millimeters of mercury for ages 2 through 6 years, 55 millimeters of mercury for ages 7 through 10, and 60 millimeters of mercury for ages 11 through 16 years. The lower fifth percentile limit of systolic blood pressure can be estimated by the formula 70 millimeters of mercury plus 2 times the age in years. Anemia and low cardiac output can aggravate brain injury and should be avoided. There's no single threshold for blood transfusion in children. Hemoglobin concentrations of 7 grams per deciliter are well tolerated by stable children in the ICU, although insufficient data exists for anemic children with marginal brain perfusion. In children with TBI, brain tissue oxygenation may improve after blood transfusion, although this response is unpredictable and typically transient. Although coronary artery disease is uncommon in children, pediatric patients can suffer from low cardiac output as a result of systemic hypoperfusion, severe brain injury, or due to medications, for example, pentobarbital, narcotics, or benzodiazepines. Propofol in particular has been reported in rare cases to result in refractory shock, metabolic acidosis, and rhabdomyolysis, a constellation referred to as propofol infusion syndrome. Propofol is therefore not recommended for use during continuous sedation in the PICU. Hyperthermia is known to be correlated with worse outcomes and longer ICU stay in patients with brain injury. Avoidance of hyperthermia is important during periods of brain ischemia. Although data in children are limited, both medications and external cooling methods to treat hyperthermia in the ICU appear to be ineffective in a significant proportion of patients. Intravascular cooling methods are more effective but unavailable for children. Promising new external cooling technology is now available for children. Hypothermia also has not demonstrated improvement in outcome and is not generally recommended, although can be considered in its moderate form, in 32 to 33 degrees Celsius, for ICP control, with careful attention to rewarming parameters. Hypothermia may also hold promise as an emerging therapeutic tool for the management of refractory status epilepticus. Respiratory decompensation in children is the most common cause of cardiorespiratory arrest. Hypoventilation can also lead to a rise in PCO2, which then increases cerebral blood volume and can lead to severe intracranial hypertension in patients with existing ICP problems and thus decreased reserve. Hypoventilation may occur in the PICU from the cerebral injury itself or by factors such as ventilator settings or narcotic administration. Children younger than 6 months are at highest risk for respiratory depression by narcotics because of their immature liver metabolism. The mean half-life of morphine can be around 5 to 5.5 hours for infants aged 1 week to 2 months. Although targeted hyperventilation may be contemplated as a temporary treatment option during periods of severe intracranial hypertension and cerebral herniation, unintentional hyperventilation has been independently associated with increased rates of mortality because a detrimental reduction in cerebral blood flow, a 1 millimeter reduction in partial pressure of CO2 is said to reduce cerebral blood flow by around 3%. Avoiding unintentional hyperventilation is especially important in the period immediately after TBI, when autoregulatory impairment can generate a mismatch between oxygen demand and supply, with a reduced cerebral blood flow relative to requirements. The approach to seizures in the ICU is based on the need for detection, reduction of the seizure burden, and minimizing secondary injury caused by seizures. Seizures can be the presenting symptom of various pathology, including ischemic injury, hemorrhage, and venous thrombosis. In parallel with acute management, an investigation of common causes of seizure should begin immediately. Causes such as metabolic derangement, drug reaction, vascular injury, infection should all be included. Early recognition and rapid treatment are essential for status epilepticus and improve the likelihood that seizures will be terminated in children. Early recognition of seizures overall can enhance the efficacy of medical therapy and reduce metabolic stress caused by the seizures. In the definition of status epilepticus, the duration of seizures has been shortened to 30 minutes. The change in parameters for the definition of status was made in response to animal studies, which demonstrated that within 15 minutes, repetitive seizures can become self-sustaining and more pharmacoresistant. A greater electrographic seizure burden in status epilepticus is associated with worse outcomes. Seizures, whether convulsive or non-convulsive, are reported in up to 50% of patients undergoing monitoring in an ICU when examined with continuous EEG monitoring. In approximately 50% of critically ill patients, non-convulsive seizures were missed by routine EEG recording but were detected with continuous EEG monitoring. When non-convulsive seizures are strongly suspected, continuous EEG monitoring for at least 12 hours is recommended. In pediatric neurocritical care, continuous EEG is increasingly becoming a standard practice. Recommendations include initiation of monitoring as early as possible in, for example, supratentorial brain injury with altered mental status, as well as altered mental status after a generalized convulsive status epilepticus or other clinically evident seizure. The authors recommend continuing such monitoring for at least 24 hours. Protocols for the treatment of status epilepticus are well established. A typical protocol would involve intravenous, rectal, or buccal administration of a short-acting benzodiazepine, followed by phenytoin, phenobarbital, or valproic acid, depending on age, current anticonvulsant drug use, or seizure type. Key features are the early identification of seizures in the ICU, consideration of continuous EEG monitoring, ready availability of anticonvulsant medication, as well as attention to individualized potential etiology for seizure. Lessons from adult stroke trials and preclinical studies highlight the need for early detection to prevent complications and improve outcomes. Imaging studies should begin with CT scanning or MRI to establish a diagnosis, to examine for possible hemorrhage, and to delineate the extent of an infarct. CT angiography or MR angiography should be included if carotid or vertebral dissection may contribute as a potential mechanism. The incidence of ischemic stroke in neonates is 20 per 100,000 live births, and the incidence after neonatal period is 2 to 6 per 100,000 children per year. The rates of mortality and neurologic morbidity associated with pediatric stroke are high, with stroke among the top 10 causes of death in children and residual neurologic deficit in 60% of survivors. The causes of stroke in children differ substantially from those of stroke in adults. Atherosclerosis in large arteries and small vessel occlusive disease are not common etiologies of pediatric cerebrovascular illness. For acute ischemic stroke, the most common risk factor is congenital or acquired heart disease. Less frequent risk factors include hypercoagulability, autoimmune disorders, and arteriopathy such as arterial dissection, moya, and vasculitis. The frequency of cervicocephalic arterial dissection as a cause for stroke is relatively high in young patients compared to adults, accounting for a percentage of pediatric stroke ranging from 8 to 20%. The presence of an unusual distribution of stroke may warrant a CT or MR venographic studies also to examine for venous thrombosis. Coagulation abnormalities implicated in increased risk of pediatric stroke can include deficiencies in protein C, protein S, or antithrombin 3, as well as activated protein C resistance, factor V Leiden mutation, prothrombin gene mutation, methylene tetrahydrofolate reductase mutation, and antiphospholipid antibody syndrome. Laboratory studies should include measurements of coagulation, platelets, homocysteine level, fasting cholesterol level, triglyceride levels, and lipoprotein A levels. Screening for infection may include antibody titers for varicella zoster, mycoplasma titer, and, if indicated, titers for chlamydia, helicobacter, and borrelia. There's an urgent need for improved therapies in children with sickle cell disease. Children with sickle cell disease are at high risk for both silent and overt infarction. In fact, up to 25% of patients with sickle cell disease have had silent infarctions without detectable neurologic deficits by adolescence. By age 45, 25% of patients with hemoglobin SS disease and 10% of patients with hemoglobin SC disease have had a stroke. Recommendations have included annual transcranial Doppler examinations for children with sickle cell disease between ages 2 and 16 years, and long-term transfusion therapy to prevent stroke in children with abnormally elevated velocities, for example, greater than 200 centimeters per second on transcranial Doppler exam. Stroke in children with sickle cell disease may occur by multiple mechanisms, including venous sinus thrombosis or arterial ischemia from acute thrombotic occlusion, as well as arterial dissection and moya syndrome. For children with sickle cell disease and acute stroke, the initial focus of clinical management is exchange transfusion and hydration. Exchange transfusion is undertaken to reduce the percentage of hemoglobin S to less than 30% of total hemoglobin, while increasing the percentage of hemoglobin A and maintaining overall hemoglobin levels at 10 to 12.5 grams per deciliter. This approach remains supported by Class C evidence rather than by randomized studies. Of note, antiplatelet therapy with aspirin has not been proven to reduce stroke frequency in this setting. The Silent Cerebral Infarct Multicenter Clinical Trial, abbreviated SIT, was a randomized single-blind clinical trial that tested whether the incidence of recurrent infarction would be lower among children with regular blood transfusion therapy compared to those who received standard care. In this study of 196 children with sickle cell anemia, regular blood transfusion therapy significantly reduced the recurrence of cerebral infarction. We know also that long-term transfusion therapy can prevent stroke in children with sickle cell disease who have abnormally elevated cerebral blood flow velocity on transcranial Doppler exam. The stroke prevention trial in sickle cell anemia, abbreviated STOP, showed that stroke occurred in 15% of patients with high blood flow velocities who did not undergo transfusion. In the SWITCH trial, standing for stroke with transfusions changing to hydroxyurea, investigators compared standard transfusion and chelation therapy to alternative treatment of hydroxyurea and phlebotomy to prevent recurrent stroke and manage iron overload in children who had undergone chronic transfusion during the 7 years before enrollment. The study was terminated early because of a lack of improvement in liver iron content on alternative treatment. Of note, stroke rate was 0% on standard treatment and 10% with alternative treatment at the time of the trial closure. Thrombolysis with tissue plasminogen activator, TPA, can be utilized for selected patients who can be treated within 3 hours or 4.5 hours of stroke symptom onset. Unfortunately, a clinical trial of TPA in pediatric stroke was terminated because of low recruitment. Thus, TPA is currently not included in children as a standard of care for pediatric acute ischemic stroke. Notably, short-term anticoagulation may be considered for pediatric stroke, pending a determination of the cause of the stroke. This is in contrast to the recommended practice in adults, for whom urgent anticoagulation is not recommended due to an absence of benefit and an increased risk of hemorrhage. As with TBI, management of acute ischemic stroke or spontaneous intracranial hemorrhage in the ICU should be aimed at minimizing secondary injury. Strategies in which fever is treated aggressively, euglycemia and normotension are maintained, and hypoxia is prevented are adapted for the management of adults with acute ischemic stroke. Although these recommendations for children are based on limited pediatric data, Class 1 Level C evidence, there is broad consensus that such management is indicated. Early neurosurgical consultation is beneficial for all cases of hemorrhagic stroke or large volume ischemic stroke. In appropriately selected patients with malignant large artery stroke, hemicraniectomy may be beneficial. The timing of decompression remains controversial, and surgical benefit is often weighed against considerations of overall blood volume and potential for intraoperative blood loss, as well as transient hemodynamic instability that can result at the moment of decompression. Children with acute brain injury and those recovering from neurosurgical procedures typically require intravenous fluids during their ICU course. Maintenance IV fluids are composed to avoid glucose and electrolyte abnormalities. Hyperglycemia, typically a blood glucose level above 180 milligrams per deciliter, is avoided because of its potential to worsen brain injury, and we should take care to avoid hypoglycemia, especially in neonates and infants. No clinical evidence is available to support the use of insulin for glucose control in pediatric patients with acute brain injury, and the use of insulin is generally not recommended in patients with severe TBI. Hypotonic fluids such as Ringer's lactate solution and 0.25% normal saline solution are avoided because of the risk of hyponatremia, which can lead to seizure and worsening of cerebral edema. In patients requiring fluid resuscitation to treat hypotension, normal saline is used as first-line therapy. In the TBI population specifically, modern guidelines support the use of hypertonic saline, 3%, as a form of hyperosmolar therapy, either as a bolus or a continuous infusion. In the case of refractory ICP, concentrated saline at 23.4% is now included in the pediatric recommendations from the Brain Trauma Foundation as a bolus based on available Class 3 evidence. Diabetes insipidus, DI, results from a deficiency of arginine vasopressin and can result in severe water and electrolyte imbalances. It develops in approximately 75% of patients after resection of certain masses such as craniopharyngioma, and in 10 to 44% of cases after transsphenoidal pituitary surgery. Treatment for children with DI can include fluid replacement alone, fluid replacement with intermittent dosing of intranasal or oral vasopressin, and fluid replacement with continuous titration of intravenous vasopressin. Patients with syndrome of appropriate ADH secretion, or SIDH, present with decreased plasma osmolality, less than 275 milliosms per kilogram, inappropriate urinary concentration with a urine osmolality greater than 100 milliosms per kilogram, and urine sodium loss greater than 40 milliequivalents per liter. with a normal salt and water intake and clinical euvolemia. The cause of SIDH can be multifactorial. Management can include sodium supplementation, and fluid restriction must be performed with care in the case that hypovolemic conditions such as cerebral salt wasting may be masquerading as SIDH. Cerebral salt wasting, CSW, is encountered less commonly and is characterized by hyponatremia, hypovolemia, natriuresis, and diuresis. Patients with cerebral salt wasting can develop severe hyponatremia and require careful titration of fluid intake and replacement of sodium, balancing the need to avoid both hypovolemia and increased sodium losses from induced diuresis. The included slide provides a summary of diagnostic criteria and comparing diabetes insipidus, SIADH, and cerebral salt wasting. When contemplating a diagnosis of brain death in children, the clinical criteria for determination of brain death include irreversible coma, a lack of motor function, and absence of all brainstem reflexes, including having apnea. Because of the difficulty in performing a brain death exam in younger patients, 2 exams are typically required. This includes apnea testing with each examination, separated by an observation period. Ancillary tests may be used to confirm brain death if components of the examination or apnea testing cannot be completed, or if uncertainty about components of the neurologic exam exist, as well as if a medication effect may be present. These ancillary tests can include nuclear medicine perfusion scan, cerebral angiography, EEG, or transcranial Doppler ultrasound. Included here is an example of documentation in the medical record using a standardized form recommended by current national guidelines. This concludes our discussion of neurocritical care in children. Thank you very much.